Now, this particular module is going to be focusing on your various lung volumes and capacities. Now, in an on-campus course, this lecture exam 4 content is usually covered in the laboratory portion of the course for time. However, we have time with the online module to make this an actual lecture module. Now, when you start thinking about measuring the amount of air that you can inhale and exhale, you're going to need a tool to do that measurement. And the tool that measures the amount of air that you're exchanging as you breathe is called a spirometer. Now, spirometers can be as simple as a little handheld device that you can forcefully blow into to get a crude idea of how much you can exhale with force. I'm going to show everyone in lab the one that we have and kind of explain what its pros and cons are. What you have here in this image is what you would have in a clinical setting where you really need to have that most precise measurement of air volume movement. The individual would have their nose plugged so that all air moving in and out of the respiratory tract is moving through the mouth. They would have this handheld device holding it up into their mouth. The device would be measuring the amount of air that's moving in and out of the respiratory tract and then transmitting that information to a computer. Now, the actual recording that you would see on the computer monitor would look similar to what you have here, maybe minus the color. The tracing that you have here is called a spirogram. And on the spirogram, in order to read it, you can see that there are upward deflections and downward deflections. An upward deflection indicates that you have inhaled. A downward deflection indicates that you have exhaled. Now, the degree of deflection indicates the volume of air that you're moving. So a small deflection means that you've moved a smaller air volume. A larger deflection means that you've moved a larger air volume. Now, one of the things that you can measure from a spirogram is something called tidal volume. Tidal volume can be abbreviated TV. It can also be abbreviated with a capital V and a subscript T, as you can see in your lecture notes. Now, the tidal volume is the volume of air that you move into and out of the lungs in one breath. Now, on average, at rest, this is about 500 milliliters of air. So this tidal volume is what you move during eupnea, that quiet breathing that you learned about in a previous lecture module. Another thing that you can determine from your spirogram, since you can actually see separate inhales and exhales, is your respiratory rate. Remember, one respiratory cycle is an inhalation, an upward deflection, followed by an exhalation, a downward deflection. So you can actually count how many breaths you've taken per minute. Using this information, you can calculate what is called your minute ventilation. Minute ventilation is abbreviated V with the subscript E. It's also referred to as minute respiratory volume. Minute ventilation is the total volume of air moved into the lungs in 1 minute. So how you can calculate it is you want to take your tidal volume, how much air you move in one breath, and multiply it by your respiratory rate. And that will give you your minute ventilation. However, minute ventilation doesn't tell you how much air you've actually used for gas exchange. Because on average, only 70% of your incoming air actually makes it to an exchange surface, meaning it makes it to your respiratory division. The remaining 30% of your incoming air which based on average tidal volume is about 150 milliliters, is in your conducting division somewhere. It's in your larynx or your trachea or your bronchi or your muscular bronchioles. So minute ventilation just says in 1 minute, here's how much air I moved. It just doesn't tell you how much air you used. Now, if you think about what did I use versus not use, you lead to a discussion of something called anatomic dead space. Anatomic dead space is abbreviated capital V with a subscript D. The anatomic dead space is the amount of air that does not undergo gas exchange. So it's that 30% that you don't use. So if you wanted to calculate your anatomic dead space, you could take your tidal volume and multiply it by 0.3. And you'd have an idea of how much air is sitting in your conducting division with that inhaled air. What you can also think about then is if we only use 70% of our incoming air, how much air am I realistically using? And that's where you might need to calculate what is called your alveolar ventilation rate, which is the capital V and a subscript A. Alveolar ventilation rate is the volume of air per minute that actually gets to that respiratory zone, gets into the structures of your respiratory division. Now, calculating alveolar ventilation rate is very similar to minute ventilation. We're just going to add in one step to calculate the 70%. So to calculate alveolar ventilation rate, you're going to take your tidal volume and multiply it by 0.7 so that you're just looking at the volume in one breath that makes it to your respiratory division. And then multiply that number by your respiratory rate. Now, from here, we're going to move into talking about forced breathing, your hypernia. However, there are some things that you need to keep in mind before we go forward. Forced breathing volumes can be influenced. Now, with tidal volume, did I mention differences between males and females? And your answer should be no. When I talked about tidal volume, I just said on average it's about 500 milliliters. Believe it or not, regardless of gender, regardless of age, regardless of body size, tidal volume is fairly average from person to person. However, when you get into forced breathing, there are differences, especially between gender. With regards to gender, males tend to have higher forceful breathing volumes than females. That is for two different reasons. In males, you tend to have larger thoracic cages, meaning the lungs are larger, and males also have stronger muscles than females on average, and with that more well-developed musculature, males can expand their thoracic cages to a greater degree than females. So they can make their containers, their lungs, bigger with force than females can, meaning they can inhale with force greater volumes of air. You have to factor in torso size. If you factor in torso size, taller people have larger torsos on average than shorter people. And if you have a larger thoracic cavity because you're taller, you're going to have bigger lungs and you're going to be able to expand that cage to a greater degree than someone who is shorter. And that's regardless of gender. This is just looking at torso size. You also have to factor in age, because as you age, your lungs will naturally lose elasticity. so they don't stretch and recoil as well as young lungs. So forceful breathing volumes actually will decline, they'll get smaller as people get older. So if you're going into respiratory therapy, if at any point you were going to have to assess a patient's respiratory capacities in general, you're going to have to factor in their gender, their height, and their age, because there are going to be different healthy averages based on all of that. So, keeping that in mind, we're going to talk about your inspiratory reserve volume first. Inspiratory reserve volume is abbreviated IRV. This is the maximum volume of air you can forcefully inhale in addition to your tidal volume. Tidal volume will always move. Tidal volume will move with quiet respiration, and tidal volume will move with forceful respiration. Inspiratory reserve is the extra that you can inhale with force on top of tidal volume. So this would be taking that deep breath in preparation for blowing out a lot of birthday candles, or that deep breath in that you take before trying to swim across a pool underwater. Now, if you look at the male and female averages, you can definitely see a huge gender effect between the two. Males on average, healthy average, is about 3,300 milliliters of air. Females on average, about 1,900 milliliters of air. And that is based on torso size. Males have larger torsos than females, and muscular development. You then have your expiratory reserve volume, which is the maximum volume of air you can forcefully exhale in addition to your tidal volume. So now this would be, as you're sitting there, take a regular breath out. Okay, so just exhale normally. Now try to force out as much additional air as you can, as if you're trying to blow out a whole bunch of candles on your cake. This is your expiratory reserve volume. Now in males, on average, healthy ERV is about 1,000 milliliters. In females, it's about 700 milliliters. And the difference again is reflecting musculature differences. Forceful exhale is all muscle, and squeezing that thoracic cage, making it as small as possible, making those lungs as small as possible. Males have stronger muscles on average than females, meaning they can just compress that cage a lot more than the female counterpart. Now, if you think about blowing out birthday candles, or any time that you have ever had to exhale with force, and you're squeezing and you're bent over, squeezing out as much air as possible, doesn't it get to the point where it seems like there's no more air to move, where you can't possibly exhale anymore? Well, a lot of people would assume at that point that all of the air has been emptied from the lungs, that you have squeezed out every bit of air from every teeny tube inside your lungs. And that actually can never happen, because after your most forceful exhale, after you remove your entire expiratory reserve volume, you still have air in your lungs. You have what is called residual volume, which is abbreviated RV. Residual volume is the air remaining in your lungs after you have forcefully exhaled your entire ERV. Residual volume is air you will never, ever be able to exhale. Once you take your first breath at birth, this volume is in those lungs. You can never remove it. Now, male lungs are a little bit larger than female lungs because their thoracic cages are a little bit bigger, So the average healthy male residual volume is about 1,200 milliliters. Females, it's about 1,100 milliliters. Now, residual volume is maintained by your intrapleural pressure. Remember when back in that very first module on chapter 22, we talked about the two pressures within the lungs? I said intrapleural pressure makes sure that your lungs stay partially inflated even after exhale. So your residual volume is maintained by intrapleural pressure. However, what if you lose your intrapleural pressure? What if you have a penetrating trauma to your chest, for example, a stab wound, and it has punctured through between the ribs and into one of your pleural cavities? Have you ever heard of collapsed lungs? Well, that's kind of where I'm going. If you penetrate into that pleural cavity, you equalize the pressure in the pleural cavity with the outside world. So instead of your intrapleural pressure being -5 centimeters of water, your intrapleural pressure is now 760 millimeters of mercury. It's equal to the outside world. And the loss of that negative pressure does cause the lung to collapse. You do lose some of your residual volume, but you don't lose all of it. You still have some air in there. It's referred to as minimal volume. Minimal volume is the air remaining in your lungs after you have lost your intrapleural pressure and some of that residual volume. Now, it's really small. It's only about 30 to 120 milliliters of air, but this should be bringing home a point for you. Even in a collapsed lung, there's still air in there. So after you take that first breath, it is not possible to remove the air from the lungs. You will always have some in there. Now, the word lung, if you actually research what that word means, where it came from, lung actually means lightweight. Lungs, when you take them out of the body, because they will always contain this minimal volume, they actually float if you put them in water, which is why they were called lungs, because they float in water. Now, here's a more unpleasant application of this. If you find a newborn infant and the newborn infant has died, and you need to determine, was the infant born alive or was it stillborn, you can actually use minimal volume to make that determination. Upon autopsy, one of the things that they will do is they will take out the fetal lungs and actually put them in a beaker of water. And if the lungs float, then it's an indication that that infant took at least one breath after birth. If the lungs sink, that means that there is zero air in those lungs, indicating that the infant was stillborn. And in these particular situations where they're trying to assess live birth versus stillborn birth, it's if they find the parents, what charges are levied. You know, that's kind of where another application for this would be. Now, based on all of those volumes, you can actually calculate certain lung capacities. For example, you might want to calculate your patient's inspiratory capacity. The inspiratory capacity is the volume of air, the maximum volume of air that can be forcefully inhaled in one cycle. So now your inspiratory capacity would include your tidal volume, because that's always going to be inhaled with a respiratory cycle, plus your inspiratory reserve. Now, for an individual with muscle paralysis, this measurement would actually be lower than average. If your muscles of forceful inspiration have been damaged, or a nerve to them has been damaged, your inspiratory reserve volume would be less than average. So this could be something to diagnose potential compliance issues. You might also have to calculate what is called a functional residual capacity. The functional residual capacity is the amount of air in the lungs after a resting exhale. So you're just going to have a quiet respiratory exhale. Just exhale your tidal volume, and then ask yourself how much air is in there. Well, it's going to have your residual volume, which is air that you will never remove, plus your expiratory reserve volume. The ERV is only exhaled if you force it out. So if you're just quietly exhaling, that volume is still in there too. Now, functional residual capacity is actually measured when you are looking at patients, let's say, with emphysema. Emphysema is a progressive disorder, and what ends up happening over time is your nice, healthy, elastic lung tissue starts to get converted over into scar tissue. And what ends up happening in people with emphysema is that when they inhale, okay, the air comes in, but because the lungs are losing their elasticity, they can't exhale out all of the air that has come in. So if you inhale 500 milliliters, you might exhale only 400 of it. And that means that that 100 that you could not exhale stays in your lungs. So over time, as emphysema progresses, their functional residual capacity increases because they're not able to exhale all of the air that's come in. And people with end-stage emphysema often have a very characteristic physical appearance. It's referred to as barrel chest, where their thoracic cage is very expanded and sort of resembles those old-fashioned oak wine barrels, because they have these lungs that are completely and totally filled with this useless air. And it's also why people with emphysema have to breathe oxygen through using an oxygen tank. They're breathing air with a higher partial pressure of oxygen to compensate for their poor gas exchange surface. They've got so much of their lungs filled with stagnant air that they're only able to use a portion of their lungs for gas exchange. They have very poor overall ventilation in there. They also have very reduced surface area because their alveoli start merging together, so they have less overall surface for gas exchange. So there are a lot of changes with emphysema. You also would have to calculate for your patient their vital capacity. I view this as the total birthday candle blowing out experience. This is the total amount of air that you can move in and out with one forceful respiratory cycle. So this would be your tidal volume, which moves all the time. It would also include your inspiratory reserve, your most forceful in, and your expiratory reserve, your most forceful out. So if you were told to take your deepest breath in and do your most forceful breath out, get as much air as you can out of your lungs, that's your vital capacity. And again, that's going to change with things like emphysema because you're going to have that impaired ability to exhale. You then might just be curious to see what is your patient's total lung capacity. And I'd kind of be curious just for personal note. Total lung capacity is how much air the lungs can hold without damage. So this would be your vital capacity plus your residual volume. Like how much air can you really put into your lungs before you risk popping those alveoli from overexpansion. Now, the module quiz accompanying this module is going to not just give you questions about the terms and definitions, but they're going to include some practice questions where you're going to have to do mathematical calculation. You will need to type into your homework the actual formula, plug the numbers in. I need to see that you've done the math. Please do not just put in the answer because I need to see that you've done the work. You will also be getting a laboratory assignment, a little homework assignment to do at home for lab that you'll be turning in as homework when you come in to take practical number 3. Now that laboratory homework, I will talk about it in lab and it will be emailed to each of you separately. So everyone's going to have different questions. So you're going to have to really learn the information in this module and then apply it to the homework that you're given for lab.